So we're still talking about the nutritional support, and now we'll deal with the additional considerations that is what you should look for in a patient with nutritional abnormality, and in certain conditions what you have to add if there are certain pre-existing conditions in your patient. So we'll talk about the infectious process. We'll see how the fever affects nutrition. We'll see organ failure in detail, and we'll talk about the nutritional changes in organ failure. Then we'll take up bariatric surgery, and we'll see how the nutrition should be managed in bariatric surgery. Then we'll talk about a special class of patients, the very old, the geriatric patients, and then we'll deal with the anomalies, that is various diseases and other complications which are present in these patients, and how the nutrition should be maintained in these patients. So starting off with the infectious process and fever. So the basal metabolic rate increases. It increases in response to the stress that has occurred to the body. In this case, the stress is the infectious process or the fever in itself. Now the total energy requirement should be calculated, and this energy requirement is slightly more than what would be in the standard non-infectious body. There is mild to moderate infection, the mild to moderate increase in the energy requirement by about 20 to 30%. Now severe infection with fever increases the caloric need by over approximately 50% above the basal levels. So in order to improve the clinical conditions of the body, you might give your patient more calories than what is required, because your body increases its basal metabolic rate and there is hypermetabolism in the body. Now, what if a patient has respiratory failure? So what would you do? Consideration should be given to the content of the nutritional support. So the respiratory quotient is very important in this case, because they may facilitate or prolong weaning in these patients, especially in chronic carbon dioxide retention. So, the respiratory quotient of a specific nutrient, which is the carbon dioxide produced over the oxygen consumed, must be known. Adjustment in the feeding should be made so that the items or the objects with high respiratory quotient, that is the carbohydrates, should be removed to lower respiratory quotient objects or items like fat. Now, with these adjustments, you can decrease the weaning time of your patient, and should always avoid overfeeding, because overfeeding causes accumulation of carbon dioxide, which would defeat the purpose of prevention of this or the prolonged weaning. It would defeat this purpose. So you should always avoid overfeeding. Now let's talk about a patient with renal failure. So how would you manage the nutrition in a patient with renal failure? So there's no change in metabolism or the catabolic rate or the protein requirements in these patients. However, there is difficulty in removal of the nitrogenous waste. So the careful balance needs to be achieved between the need for protein and to limit the uremia. So total parental nutrition with amino acids of high biological value may improve survival in acute renal failure. Now, users of solutions with high quality amino acids, they improve the nitrogen balance and minimize the urea production. So you need to achieve a balance. You should always give specific high biological value amino acids so that they can be incorporated into the new proteins that are being built. At the same time, they cause minimum uremia. Now, what is with the liver failure? So if a patient has liver failure, how will you manage the nutrition? These patients will tolerate protein poorly, so they develop derangements in the circulating level of amino acids. Now there's the plasma aromatic to branching amino acid is increased. This favors the transport of amino acid across the blood-brain barrier and causes worsening of the encephalopathy. So using solutions which are enriched in branch chain amino acids and deficient in aromatic amino acids, it enhances the protein tolerance and improves the encephalopathy. But it's a complicated scenario, and always a nutritionist and a senior physician should be involved. Now let's talk of heart failure. A patient has heart failure. How to manage nutrition in this patient? So patient with surgical emergencies, these are the patients with surgical emergencies commonly of the third space, that is the fluid is being lost into the third space. They require a significant amount of crystalloid resuscitation fluids. This may exacerbate their pre-existing volume overload. So these patients are already in volume overload, which is being lost in the third space. Now you might resuscitate these patients with crystalloids. This crystalloids would increase their already increased volume overload. So minimize total fluid in these patients. The total fluid volume given to these patients should be minimum. The nutritional formula should be as concentrated as possible for these patients because you want to limit the fluid overload in these patients. Now let's talk about bariatric surgery. So the people who are undergoing bariatric surgery or who have already underwent bariatric surgery, how do you treat them? So how do you maintain nutrition for them? These are chronically overnourished patients. Now they have altered gastrointestinal tract. This increases the risk of several macro and micronutrient deficiencies. So the nutritional support is very complex and should always include a nutritionist with you. You should receive early and they should receive early and timely nutrition because they have a limited segment of the functional bowel. They have either had bariatric surgery before or their guts have been specialized so that they receive early and timely nutrition. There's consideration for indirect calorimetry in these patients because they need precise amounts of calories as well as the nutrition. Early involvement of nutritionist is very helpful in these patients. Moving on to the geriatric patients, these are the old patients which which are undergoing polypharmacy. There are multiple diseases acting in the same patient. So physiological alterations need to be seen in older age. Even if the patient is not suffering from great many diseases, there are physiological alterations in their body which need to be taken into account. Usually there are numerous disease processes as well. The pre-operative goal is to maintain a higher protein intake which is greater than 1.5 gram per kg per day. Now we can have enterocutaneous fistulas. So gastrointestinal cutaneous or gastrointestinal atmospheric fistulas with high output can be there. They are classic indication for a long-term TPN. So one of the classic indications of long-term TPN is this. The oral intake results in greater output. Now, TPN increases the spontaneous rate of closure of the enterocutaneous fistula by improving the overall nutrition status in the host as well as improving the perioperative outcomes in those that require surgery. So, TPN actually gives a rest to the gastrointestinal tract, as a result of which it can heal itself and heal the enterocutaneous fistulas. Now, somatostatin and analog aids with fistulous output and spontaneous closure. So these, as the somatostatin and analogs, they aid in the closure of these fistulas and also with the fistula output. So they can also be used. Now, short bowel syndrome. So, in short bowel syndrome, a small portion of bowel is functional, the rest is non functional. So, how will you maintain the nutrition in these patients? So, they have history of extensive bowel resection. So, they lose a large part of their absorptive ability of their bowel. They have to rely on TPN for longer periods of time to maintain their nutritional goals. Moving on to the major thermal injuries. So, burn victims suffer from prolonged ileus or anorexia, which encumbers enterals nutritional support. There's anorexia of severe injury as well in these patients. There are frequent NP or nil per oral, that is, you cannot give them anything through their mouth for repeated trips to the operating room because you have to correct their alimentary canal. So, aggressive nutritional support with high protein intake is associated with improved survival in these patients. So, TPN is clearly the better option here. Now, what if a patient has prolonged post-operative ileus? So it precludes the use of intestinal tract as a feeding route. So if patient is unable to eat by post-operative day 5 to 7, TPN should be considered because the nutrition has to be maintained. It prevents a further erosion of lean body mass. So for 5 to 7 days, the lean body mass of the lean mass of the body has been is being undergoing a lot of destruction, catabolism, because the body has to utilize energy from somewhere. So you have to start the patient as early as possible on TPN, so that is not a great, not further, so to prevent the further loss of total of the lean body mass. Now, when the post-operative ileus is of shorter duration, you can use other methods such as PPN for nutrition. So moving on, we can have acute radiation and chemotherapy enteritis. So now the patient is malnourished and is receiving abdominopelvic radiation or chemotherapy. They develop mucositis, that is inflammation of the mucosa, enterocolitis, that is inflammation of the intestines. So in these, the parenteral nutrition should be provided until the enteritis resolves and oral feeding can be resumed. So these were few of the conditions which you commonly come across with your surgical patients. And all these patients, you just have to tailor your nutrition and make sure your patient is getting the nutrition what he requires. The crux of all the entirety of this lecture was you have to maintain and tailor your nutrition according to your patient. You would always do what is in the best interest of your patient. Keep your patient in the light. Keep discussing whatever is going on with your patient and try to maintain the nutrition. The better the nutrition, the better the chances of your patient to improve, and the lesser the stay in the hospital. I hope you liked and enjoyed this lecture. For further such lectures, keep watching sqadia.com.